Hi, welcome everybody to Casual Conversations. I so appreciate you making time to come with everything that's going on. It suddenly seems like there are conferences popping up every day. I appreciate you coming to our show today, which is based on the brain injury magazine, Women versus Brain Injury. And I'm really excited to have Dr. Tina Master back today to speak with us about updates since she was last here in December. And I think we'll just start right away. Hi, Tina. How are you doing today?
Great, Catherine. Thank you so much for having me. This is a great turnout.
Well, it was so you were hit the first time where I think it was our second episode, and I was still trying to figure out. It was supposed to be a 4 episode event, and I think this is number 16 or 17 today. So
Amazing.
it's because people keep showing up, and my guests are so fabulous. So why don't you just give a little introduction for people that didn't see you in December on how you got to bring a little bit about growing up and how you got into the brain injury field.
Yeah, no, that's great. Thank you. I am a pediatric sports medicine specialist. And I actually started out as an academic general pediatrician, and I'm at the Children's Hospital of Philadelphia, where I grew up and trained, and was the vice program director there for the residency training program for 17 years. I developed an interest in mild traumatic brain injury and concussion actually as my kids and my patients grew up and were getting more active in sports and getting injuries. My oldest son and my youngest son now actually also played ice hockey. And one of his early coaches in his youth hockey days was Keith Primo when he first retired from the Philadelphia Flyers due to concussions. And I remember that was in the early 2000s. And I thought to myself, it's just amazing to me that we still don't understand that much about concussions. And so when the opportunity arose for me to take a sabbatical year and do sports medicine fellowship training, I did that at the Hospital University of Pennsylvania next door. And then came back to CHOP to start our sports medicine fellowship program there with Matt Grady, and then have been working on both concussion clinical care and research and building our program there with both Matt Grady on the clinical side and Christy Arbogast, our biomedical engineer, on the research side. And so I've been in concussion clinical care and research now for about 11 years, and it's been just a great experience. So really lucky to have this job.
We have about the same time frame as parents, and my kids were playing youth sports and my son concussed in 2008, and it really was an interesting time because you had the Bob Cantu's
Mhm.
classifications of concussion based on loss of consciousness kind of put aside, right? That wasn't working for everybody
Mhm.
because it was based on loss of consciousness. And then you had this sort of newer adopted view of concussion that only 1 out of 10 had loss of consciousness. You
Right.
had the NFL litigation crossing with Bennett Amalu and all of the sports interest with the
Yeah.
youth sports. And then in 2009, you had the CDC coming out with their range of stickers, notebooks, clipboards,
Right.
heads up. There was a lot of material, a lot of interest, not a lot of implementation planning, but there was a lot
Mhm.
of
Mhm.
freedom to kind of jump in and find a place to hang your hat.
Yeah, no, I mean, I guess I think that you're 100% correct that the last decade has really, seen an explosion both in interest in concussion as well as research. And so I think many of you probably heard at some talk at some point about how there have been more research articles published about concussion in the last, 10 years than, in the last 100 when they first started indexing medical research. And so I think from that standpoint, it just shows you how important it is in terms of recognizing and keeping up with all the changes that are going on. And I think one of the things that has made a huge difference is that the sports awareness, did raise awareness about concussion in general. So I think that, I'm on another committee now where we're talking about TBI and why it doesn't get the same kind of, attention or research funding as, cancer, for instance, or cardiac disease. And, we talk a little bit about how TBI needs like a rebranding campaign. And I do think that everything that we've been learning in the last 10 years makes a big difference. And the fact that, sports is a common cause is very important and has raised awareness for everything, even non-sports mechanisms of injury for concussion. So that's been a good thing all around. And so I think from that standpoint, some of the work that we did here at CHOP in conjunction with Julie Harbaugh-Krupa, who I see is on today, we made a big point of trying to point out that in childhood, at least for sure, sports is only a part of the story. Probably 60% of our kids had concussions in sports, but if you look at the broad spectrum, kids get concussions, in daily life, and other things besides recreation and play. And so it's not just about sports, but sports was a good way of raising awareness for sure.
And I think the CDC's Heads Up campaign suddenly gave everybody something to put in their hands. So
Absolutely.
as running a youth sports league with about 700 kids in my city, I suddenly could order. You literally, it was like a candy shop. You could go on and order whatever you wanted, and it would come in a box for free. And then I would run a sports concussion night for our coaches. And then the football people down the street found out I was doing it. So I literally started going team to team around our city and then to other cities with the CDC information in hand and the coaches training. But I was always talking about the non-sports concussions too, because I felt that they weren't getting the same amount of attention.
Absolutely. Absolutely.
But that's what I think, that's what the interest is. And there's a 2012 study that showed that you had a 80% chance of your parents taking you in after a suspected head injury if you it was on a sports field, but only a 50% chance if your parents were home. It was in the backyard, like sports versus a non-sports setting.
Yeah.
And
Yeah.
what I was noticing in youth sports concussion at the time was that the boys' parents were calling me literally from the mountain. We're leaving the mountain. We think it's a concussion. We're going to the ER. Or the boy, and I had 3 boys, so I mostly knew them. The boy parents were calling me, we've left the ER. And we were talking about this earlier. The parents of girls would call me and say, she's been out of school for 3 weeks in a dark room and she's sobbing uncontrollably. I think she has a concussion. And the pattern of when I would get calls from the girls' parents versus the patterns of the boys' parents, really, as a boy parent, I was just sort of annoyed by the girl parents. And so I looked into the research. That's where I saw Tracy Kavassan's work, created Pink Concussions, as a resource for girls. And your study with CHOP, which I'd like you to talk, but really underline what I was seeing years earlier.
Yeah, no, I think it's really interesting because I do think there are a lot of factors that I think probably come into play that we still haven't completely disentangled to understand in terms of what the differences are in terms of both sex differences with concussion, which are biologic and intrinsic, versus gender differences with concussion, which are sociocultural or extrinsic. And so I think from that standpoint, there may be ways that we can actually, modify those extrinsic behavioral aspects. And I know that definitely all the efforts in the last decade in terms of raising awareness generally, but then education in particular, I think makes a big difference. I think education of parents and education of all athletes across the board, but particularly girls, to make sure that they're self-identifying their symptoms, the injuries and how they happen. And there's been some, good research out there that demonstrates that, girls actually do respond well to those educational interventions and do, make a plan then to disclose when they have injuries. And so I think that that's been helpful. What was interesting about the study that we did at CHOP that you're referring to, that was led by one of our sports medicine fellows, Natasha Desai, who is now in New York City practicing at Columbia. um, she was really interested in just looking at the differences potentially, if there were any, between girls who presented for care for concussion in our program versus boys. And it was just a very open-ended question. And it was a really good example of why we do research, right? We have a hunch as to what we think we're going to find. We're going to look at the data to see if it either confirms that or refutes it. And we have to have an open mind, whichever way it goes, because if we already knew the answer, we wouldn't have to do the research, right? And
Right.
so what was interesting was that our group, as you know, has been very interested in visual and vestibular disorders after a concussion, that basically those systems get injured and they can really have a big effect on kids' return to school, return to activities, return to sports, return to driving. All of those things are affected by visual problems and vestibular and motion sensitivity problems. And so we were interested in looking at that. And what we found was that girls certainly did have those at a high rate, as did boys. So there wasn't actually a difference with regard to that, although others have reported that. So our colleagues out in Pittsburgh have reported that girls had higher scores on vestibular ocular reflex testing as part of their assessment. But we didn't see that difference in our group of kids, and they were ages 7 to 18. But what we did find was that they had higher symptoms across the board, and took longer to recover on pretty much every outcome measure we were interested in. So whether it was return to school, return to exercise, like non-contact exercise, then full return to sport, recovery of their neurocognitive function using the assessment that we used, and recovery of their visual and vestibular deficits. All of those took longer in girls to recover than boys. And so that sort of made us feel like, okay, we're sort of onto something here. And then it was interesting because almost as an afterthought, we kind of do this regularly just to do like internal and external checks on our data. We did a sensitivity analysis where we basically looked at the girls who presented a little bit earlier versus later, because we do know at CHOP, we tend to take care of a referral population. We're not an ER, we're not looking at kids in our concussion program that are in the ER first thing, or in their primary care doctor's offices, which a lot of kids go to first, as we had demonstrated in some of our CDC work with Julie. And so we were looking at these kids in a specialty set context. And what we found was that when we looked at girls who presented within 7 days to our specialty practice, they actually recovered at similar rates to the boys. And so that was actually a little bit astounding to us, because that's not what we expected. And then I really realized in looking at that I had been carrying around this implicit bias, and so there's been a lot of talk, this last year about implicit biases and how we have, all of these things that we are not necessarily aware of. And I was a little bit ashamed to say that I was a sexist, right? That basically I had internalized a lot of the data that's out there, that there are differences between girls and boys and men and women, that are absolutely legitimately, biological sex differences. So, down to the point where, our colleagues next door at the Hospital of University of Pennsylvania, with Doug Smith and his group, one of his lab members, JP Dole, had done a study that showed that female neurons are smaller. They get injured more. They function less well after they get a laboratory injury compared to male neurons, and so it was just very interesting that, all of that data that demonstrates that there are neuroimaging differences, there are, biological cellular differences, and there are, blood biomarker differences that people are describing, that there are symptom differences and the recovery differences. I had just internalized that to mean, well, boy, it just kind of stinks to be a girl if you get a concussion, right? Because it's just going to be bad news. And when we saw in our data that it said that actually if they got earlier care, they had same outcomes as boys, I thought, holy cow, that there's an interaction here between biological factors of sex and extrinsic factors that could actually ameliorate those potential negative outcomes due to sex. And so from that standpoint, that was, I think, a real eye opener, both for me and our group, and then sort of has led us down this path in terms of the different studies that we've been able to do since then. So in a way, it's very exciting, right? That basically, if we can actually literally level the playing field for girls, they can have outcomes as good as boys. And so that was, I think, the take home for us that was surprising. And then that's been borne out actually by our colleagues in Pittsburgh. So Anthony Contos and Mickey Collins and their group had demonstrated that for all comers, boys and girls, if they got earlier care, they had better outcomes and recovered more quickly, right? So I think that from that standpoint, those extrinsic factors not only can improve outcomes for girls, they can improve outcomes for boys. And, I'm preaching to the choir here because everybody here, who is interested in TBI knows that if you can get the right care at the right time, in a timely way, you will have better outcomes, and so I think that that's really one of the take homes.
Yeah, absolutely. And as we were talking earlier, as far as pink concussions, if it turned, I was waiting for those pictures of the neurons. I did want to see the pictures. I mean, I remember 10 years ago saying, when we have a picture to show this. So I do think the study is very important, but I also feel like all this data shouldn't limit what girls are able to accomplish in sports or in the military or in first responder or as fire police. None of this I feel like should limit a woman's ability to do whatever she wants to do. But when an injury occurs, how can that care be at the highest level that it can be, equal to a man's the care? And so that this issue also came up with the NCAA study I wanted to talk to you about today,
Yeah.
and the Division 1 versus Division 2 versus Division 3 schools and the different levels of medical care those athletes had.
Yeah, no. So that paper that you're describing that just came out late last year was essentially a little bit of a follow up to our interesting finding that we saw in our girls at CHOP. And so I think the study that you're referring to is one from the CARE consortium that we were part of. And so as part of University of Pennsylvania, we were one of the institutions that were one of the 31 colleges and service academies that participated in the largest cohort study of collegiate athletes in concussion to date. And from that standpoint, we were interested in looking at potential sex differences between male and female athletes. And what we chose to do with that was that we wanted to only use the sports that had both male and then female teams, men's and women's teams. So that automatically eliminated sports like American football. We felt like that was going to be useful because so much of concussion is about American football, and that can skew numbers one way or the other because they're just it's like a steamroller in terms of the numbers and the numbers of concussions and injuries. And so we ended up looking at basically sports where they were matched. So soccer, lacrosse, ice hockey, cheerleading, track and field. And so we looked at them at all levels of contact. So, full contact, limited contact, no non-contact. And then we also looked at them at division level of play. So Division 1, Division 2, Division 3 in terms of level of competition.
And
And
just
oh
to
yeah,
state, the Division 1 are in the United States are our largest schools. They're the most funded and have a higher degree, have full scholarships. Down to D3 that don't have financial scholarships are smaller school, the smallest schools, right? It's about the size of the school and the
level of competition. Yes.
right level of competition. And along with that competition comes the ability to have medical care at that level. So like the D1 schools have almost professional medical team.
Yeah, yeah, no, so I think what you're referring to is really a great point. And so when we looked at our data with regard to looking at men and women athletes in the collegiate level, what we found was that in terms of just like pre-injury characteristics, there were sort of like the typical things that you would expect to find that the females were more likely to have a history of migraines. They did report more baseline symptoms even before injury than males did. And so those sort of held true and kind of confirmed what others have published in terms of symptom reporting. And then in terms of injury, there were, some differences that were interesting in terms of injury, that basically the women were more likely to get injured in practice rather than competition, and men were more likely to get injured in competition. The women were more likely to get injured by equipment like a ball or a puck or a stick, as opposed to men who are more likely to get injured by an opponent. And then it was interesting because there was no difference between the sexes in terms of the rates of loss of consciousness, but the men had higher rates of post-traumatic amnesia. And so those were just some interesting sort of, comparisons that we found just in looking at comparing the groups. When we looked at recovery though, and our main outcome measure was full return to play, so full return to their sport, When we looked overall at all comers in terms of the male and female athletes, there was no difference actually in the time to recovery. And so again, even with my come awareness from the previous study that we had, where I had a comeuppance and realizing that my bias about women always taking longer to get better wasn't the case always in pediatrics. I still was carrying that into my college study that we were doing, and lo and behold, that turned out to be not the case. That all comers, the girls and the boys, the females and the males recovered in a similar rate and similar time frame. What was interesting then was when we started to slice it up like you described, by contact level, within sex, and then by division level. And so when we looked at the contact level, what was interesting was that full contact females took longer to recover than full contact males. Full contact, non-contact females took longer to recover than non-contact males. But the limited contact males took a lot longer to recover than the limited contact females. So it was kind of like the reverse. And so you look at that and you think, well, that can't be, explained by a biological phenomenon. That's not a sex difference. That's got to be a combination of both some sex differences and some extrinsic factors that are resulting in that. And so then we looked actually then within sex, so that, if you looked at just the girls, the full contact girls actually took longer to recover than their limited and non-contact female athletes. And then among the male athletes, the limited contact men took much longer to recover than the contact and non-contact men. So again, a little bit of a puzzling kind of result that we would, be led to believe, really is not related to necessarily a biological intrinsic, sex difference or anything along those lines, or even necessarily a sport difference, but that from this standpoint, there's something going on extrinsically that may be at play here that's resulting in these differences. And so then we looked at it by division level of play, and what we found was that in the division 1 level, the males and females recovered at similar rates. But at the division 2 and 3 level, the females took longer to recover. And so then that sort of got our sort of like, thinking, cap going in terms of what could be accounting for that. Obviously, it's an observational study, so we can't directly determine, cause and effect, but we can speculate, right, as to what might be resulting in this. And so the couple of thoughts that we certainly had in terms of interpreting our somewhat, in conflicting data was that overall, men and women recovered at similar rates. And we might argue that actually this might be absolutely a tangible effect of Title IX, that essentially, that federal legislation in 1972 that ensured equal access to, any kind of educational resource for an educational institution that receives federal funding, not only leveled the playing field for men and women with regard to access to sports, it may have leveled the playing field with regard to access to sports medical care, athletic training care. Then I think what we thought may have been going on in terms of the limited contact men and the Division 2 and Division 3 females goes along with some research that's been coming out recently by Christine Baugh and her group that she published in the Journal of Athletic Training last year, where basically there is definitely there are differences that you can see with regard to the medical model. So that if you have a medical model where your sports medical team and athletic trainers report to a medical, director as opposed to the athletic director, there were differences with regard to injury and outcomes. And they found that basically at the Division 1 level, those athletic trainers had a lower patient load. So there was a high ratio of medical staff, athletic training staff, to athletes, as opposed to in the Division 2 and 3 level, where there were fewer medical staff and athletic training staff and a greater patient load. And what they found that there were lower rates of injury, both initial injury as well as recurrent injury. And this was all injuries, not just concussion, but musculoskeletal included. There were lower rates of injury and re-injury at the D1 level, where they had lower patient loads and more medical care and more athletic training care. So I think that from that standpoint, I guess what we would argue would be, a potential way forward is that, clearly Title IX has had a huge impact on many things, and one of them may be this access to both sports as well as sports medical care. But Title IX is also going to be 50 years old next year. And so, what can we do to move things forward in terms of making sure then that any of these, benefits that they're really realized across sexes, but also across divisions. So we don't want to have those limited contact men suffering just because they're in limited contact sports, in the same way that we don't want women to be suffering because they don't have athletic training or medical staff, coverage. And so I think from that standpoint, I would sort of then just highlight, an article that you'll probably be familiar with that came out last year from the CARE Consortium, and Mike McCrae was lead author on that compared football and concussion in the 2010 era with CARE versus the original NCAA football study, which was in the late 90s, early 2000s. And what they found was that in the intervening decade, there were such changes in terms of identification and management and gradual return to play with a symptom-free waiting period, that what they found was that, in the late 90s and early 2000s, lots of those football athletes actually returned to play within a few days, 3 days, 4 or 5 days, it was pretty quick. Whereas in the CARE Consortium era, the 2000 teens, they were taking, up to 2 weeks, potentially, 10 days to 2 weeks to get back to full play. And that had a tangible impact on outcomes in that the rate of repeat concussion, the median time to repeat concussion back in the late 90s was 4 days. So you get back from your concussion and you get another concussion within 4 days. That was the median time. In the CARE Consortium era, which was the 2000 teens, with the changes in practice, in management, and the symptom-free waiting period and the return to play process, the median time to a repeat concussion in the 2000 teens was 49 days, right? So I guess what I would say is that, a lot can change in 10 years in terms of behavior change, in terms of culture change. And so I think that as we continue to identify these disparities, obviously some of these differences may be intrinsic and biological, but those biological differences, genes do not have to be our destiny. We can actually make a difference with extrinsic factors that are structural or systemic in nature, that can actually have a really positive impact in improving outcomes across the board, for females as well as males.
Absolutely. And back to the women versus men is, are we funding athletic trainers to be on the sidelines for women? And is medical care assigned by the value of the player to the school? Do the players that make the most money for the school, are those the ones that get the best medical care? And even down at the high school level, our Connecticut law has protections for the students that play, that are specifically play for their school athletes, as opposed to the students that are in gym class and get a concussion. So, the level of your play, your ability as a athlete, creates a value, and that value may be determine the kind of medical care that you'll get.
Yeah, so I think that's really interesting. And obviously, I'm not sure if you're asking that question more rhetorically or really excite me to answer that because,
No,
yeah,
from a rhetorical, because I was talking
yeah,
about it.
exactly. No, I know. I'm just teasing. I just think that, obviously that question gets raised all the time. And even at the collegiate level with Title IX, I think it differs at different schools, and so I am fortunate that, University of Pennsylvania is the college that I work with, and they have, great athletic training coverage, with, athletic trainers really available 24/7, certainly also on the sidelines. There's definitely data and research out there that shows that at the high school level, high schools that have athletic trainers at girls soccer games, girls basketball games, they have better outcomes with their concussions. And so there's no Title IX at the youth level, obviously. And so that is a big discrepancy. If you have a valuable, rare resource like an athletic trainer and you are a high school and you have to pick and choose, you're going to send your athletic trainer to football because that's where the biggest and most serious injuries generally happen. But that does, raise the question as to what about all the other sports, boys and girls included. I think in terms of, with regard to college, I think that, having them on the sideline is a huge benefit. Certainly having access to them and being able to reach them in the training room is one thing, but there's definitely yet another level of even, sort of pre-triage, vigilance when you have an athletic trainer on the sideline observing and seeing what's happening, in a game. And if something happens, being able to pull somebody out and assess them right away, which, again, from data from the CARE Consortium, Brett Askin did a great paper that demonstrated that athletes that got pulled out sooner actually recovered sooner and got back sooner. And getting pulled out as soon as possible really probably practically means having an athletic trainer on the sideline.
Absolutely, and I do believe in training youth parents, and the CDC training. I mean, I've trained hundreds and hundreds of parents that after a 1 hour training program went out and saw sports in a completely different way.
Yep.
Coaches saw it in a different way and said,
Yes.
"Now I see concussions when I didn't see
Yes.
them before," and even with
Absolutely.
watching professional sports. So
Yep.
I do believe that this is it's everybody taking responsibility of the education, parents supporting school boards in hiring athletic trainers, and that is part of the funding that's considered when somebody plays a sport is, do we have the right medical care for the sport that child, male or female, is playing?
Yeah, I do think that if we can move the ball a little bit forward in terms of incorporating that kind of athletic training and medical care into the cost of doing business for sports at the youth level, I think it would make a big difference for sure.
I did have in my notes that your biomechanics study.
Yeah, no, no, no. And so I think, we just also our group, because we are really fortunate to work with Christy Arbogast, who is a biomedical engineer, and we
Who
have
I went on tour with once. I love her.
yeah, she
So
is.
great, and discusses biomechanics in a way that like I
Yeah,
can understand
you
it.
should have her on. You should have her on one of these episodes because she would be great. She's so great at explaining very complicated engineering concepts to even like dummies like a pediatrician like me. So, um, but what we just published recently with one of our graduate students, Colin Huber, who's an engineering grad student at Penn, we have a study going on right now, funded by the NIH, to look at head impact exposure with sensors. And so again, another area, another gap in the research is that most of the sensor research that has gone on to date has been in football primarily. But then after football, it's been in helmeted sports, right? And so again, from that standpoint, females and girls sports, especially, youth girls sports, are particularly understudied from that standpoint. And so we essentially were looking at head impact exposures in some non-helmeted sports with this study that we did. We looked at soccer, basketball, lacrosse, and also field hockey, and they all wore a headband mounted impact sensor over a few seasons. And we were just basically trying to get an idea of what their impact exposure looked like in a season. So this is starting to get a little bit at that whole concept of, what are the subconcussive exposures that kids are experiencing? Because I think one of the things that, we've been trying to convince, both, large funders like the NIH or the Department of Defense is that, or even the NFL, adults don't show up, to the combine or to training camp or, to whatever, adult role that they have in sports, a blank slate. They have a history, and that history is probably a pretty complicated history in youth sports in terms of head impact exposure. And we need to not just start studying people when they're in high school and college, or college or professional level, because by then, at least, for a pediatrician like myself, the horse is out of the barn. We've missed all the interesting stuff that's gone on in childhood. And so from that standpoint, what we found was that, in this study of high school athletes, they were all varsity athletes. There were differences in the impact rates that were experienced, that the male players had higher head impact rates than female players in both soccer and basketball and lacrosse. And that from that standpoint, in soccer, most of the impacts were head to ball. In basketball, they're mostly, player to player. And the impact mechanisms actually were very similar between boys and girls, in this high school varsity cohort. And so from that standpoint, again, just recognizing that there are some sports that seem to have higher rates of head impact. And so that's going to increase your risk of concussion, but also will increase your exposure. And we still have yet a lot to understand about what that exposure means, either in the short, medium, or long term. So hopefully we'll have more to report on that moving forward, to see. But that was just sort of a little first taste of sort of what we're looking at.
Well, I love talking to you. You and I could talk all day about this. I do want to give a chance to open it up, and I've seen some. There are a couple of questions that have gone by. Let me change my view now. And I guess one thing I just want to end with, which I know you and I both believe that, your genes aren't your destiny, that we have the choice today. If we exercise, we have the choice of what we eat today. We have the choice of our stress levels, meditation, mindfulness, that there's so many factors that determine our neurological state in the moment and in the future. And that this is all taken in combination with that. Just because you have a history of multiple concussions or you played a particular sport, that isn't a reason to look forward and, the outcome is going to be dreary, that
Yep.
we
Yep.
all have choices.
Yep. Absolutely.
Um, and I think that's really important. I think too often that I've worked with people where, they've been told you have to retire, you must retire from sports. And it sounds like you're going to be, sitting, playing tiddlywinks the rest of your life. And that we never truly retire from the need to exercise, that it's about modification and, moving forward, what can we do to be the healthiest us?
Yeah, absolutely. I think that was one of the huge things about practicing pediatric sports medicine and taking care of concussions, is that we can't tell our kids, to retire from life, like that's just like not reasonable. And so I think that the whole professional sports model and how it's perceived was a little bit stilted in that, fine, they retire and they move on and nobody pays attention to what happens after that. But for kids, it's different. And I think actually there's a great comment here in the chat from Lisa Love about how there isn't awareness as much as cancer because there isn't a medical money model to capitalize, because there isn't a high dollar treatment for concussion. And so from that standpoint, I think that she's 100% correct. And that actually is, I think, the next frontier that we really have to crack. It's not just about identification and diagnosis and predicting and prognosis. The goal has got to be to treat. And right now, what we would say is that it's not like we're not treating concussion right now. And I do think that another rebranding that TBI could really benefit from is the fact that TBI of all sorts, mild, moderate, and severe, is very treatable. And the rehab actually works. The right types, the right amount, at the right time with the right people can make a huge impact on outcomes, both in concussion and mild, as well as in moderate and severe. And so I do think that really, as opposed to like thinking about TBI as being like a downer of a diagnosis and kind of a depressing thing to talk about, TBI, MTBI, and concussion actually we can be very, very optimistic and hopeful, because there are a lot of things that can be done to optimize outcomes. And so that would be the parting message that I would definitely want to leave with.
Absolutely. And I think what people don't realize is brain injury has been the unwanted stepchild in the neurology field. I mean, we literally just got to the big people's table. We're still probably in a booster seat compared to the other ones. And I was invited to the NIH meeting on redefining or the tightening up the CTE definition, and the Alzheimer people were there to observe, and they were kind of patting us on the head going, we remember when we were starting our brain banks, and they were like, you guys are so sweet. And we really are on the we are we are on the newer edge, right, of the discovery, which I think is the exciting part. We're learning so much more. We need more money to do research. We haven't blown a ton of it in the way that and I know Alzheimer's is kicking up their fundraising right now too. But maybe that as we move forward with these new advances, it can help all the Alzheimer's, multiple sclerosis, Dewey body, the other everybody else that's competing for that same mind dollar. But it is the final frontier.
Yep. I think we'll crack it. We will.
I'm excited. So we have another question, which actually was to me about, hold on, let me pull that up. Comments about the impact of hormone levels and the impact of TBI on hormone levels. I have had multiple conversations with Dr. McCrae, Broglia, and McCrory. Oh, I mean, not McCrory, Broglia, McAllister, McCrae over female hormones aspects for the NCAA study. And at the time, they felt that it just would expand beyond the capacity and add another multiple layer. I'm still pushing on that part. Do you have any thoughts on the hormone aspect of looking at that as far as future TBI research?
Yeah, no, and I think that from that standpoint, there's been a lot of interest in that. There have been studies that have shown that depending on when you're injured and what part of the cycle you are in, you can have a better or a worse, outcome or injury as a result of that. There was a huge trial that actually was conducted using progesterone that ended up being terminated because they did not find that it actually made a difference with that. And there's a lot of different opinions as to why that panned out, and perhaps we need to do a little bit better, to identify who goes into and enrolls in these studies. So I think from that standpoint, we still have to figure out, what it means in terms of being, in a particular phase in the cycle. There's also been, data that shows that if women are on oral contraceptives, which essentially, is external hormones, that may mitigate some of the, problems with, the part of the cycle that you're in when you're injured. So that's, again, a question that should be examined in a larger cohort for sure. And then lastly, there's definitely data that shows that even with concussion and mild traumatic brain injury, there can be impact on the hormonal cycle, where there are a lot of teenage girls and young women who, after a concussion or mild traumatic brain injury, have alteration of their cycle, either losing or having changes in their menstrual cycle as a result, presumably of some effect of the impact on their pituitary and the hypothalamic pituitary axis. And so, yeah, there's a whole lot that still has to be understood in that arena, but some interesting ground, work to start with, and I think more that needs to be done.
And then we have a comment from Julie here. She said, appreciate your talk, Tina. Nice to see so many people here. A question for Catherine, Tina, the group. What do you see as research gaps in the field of concussion and MTBI? So my particular one that I've been dragging my soapbox around is the hormone aspect. And we actually have a speaker next week. Oh, hi, John. John McCormick's coming in. Hi, John. Welcome. We are just talking about gaps in future research. Rachel Rowe, who is actually in the audience, she's going to be speaking next week. She's a researcher on sleep and hormone disruption after TBI. So we'll be talking that next week about that with Rachel. But what other gaps do you see, Tina, in your view, which is pediatrics, sport, college? Like where would you, like, if you were given $10 million, where would you want to put it?
I do think that, again, treatment is the ultimate goal. And so I think that I don't know that we're going to be able to, do it like in a nice sequential manner, which we would all love to do, is be able to like accurately diagnose and then prognose and then treat and then do those studies all in that sequential order. We're probably going to be coming at it all kind of at the same time. I think that there have been really good advances in terms of diagnosis. I think the issue with the diagnostic portion is really recognizing that there are probably different subtypes of concussion. And so you can't just enroll everybody with a concussion into a clinical trial, because again, there has to be some kind of precision to that, because there's got to be some way of being able to predict who's going to respond to what kind of treatment. And so I think that's sort of where the linkage has to come in terms of how you do the diagnosis, and then how you enroll them in a trial. And then, mixed in there will be, how do you predict who's going to do better or not do better? Because the people who aren't going to do better, we want to figure out what are the interventions that we can do and when should we do them, right? And so we just wrapped up a small pilot randomized control trial of exercise after concussion with John Letty and Bill Meehan and Rebecca Mannix in Boston. And from that standpoint, really are, recognizing that, non-contact, low risk aerobic exercise that is limited and targeted using a heart rate as your, outcome measure, actually can make a difference in terms of preventing persistent postconcussive syndrome. And so that's late breaking, news, and hopefully will be published soon. But again, from that standpoint, those are the kinds of studies that we need to do in terms of identifying, kids who may be at risk, people who may be at risk for having longer symptoms, and how do we make an intervention? How do we time that intervention?
Absolutely. I totally agree. And I'm a big fan of John's. And we had Dr. Nader from John's lab on to talk about, and that's been a very popular episode from people to watch. Let's see if there's another question. It's also, we have about 10 minutes, 15 minutes left. Would anyone like to unmic? This is supposed to be a conversation, and you have Dr. Master here and ask a question. People keep coming into the room. There's more, people keep joining. Julie, on mic. I want to hear your voice, Julie. I'm going to read, but I'd rather Julie on mic. Come on, Julie. Or maybe you're not in a place where you can on mic.
Yes. Hi, everybody. Can you hear me?
Yes, I love hearing your voice.
Oh, thank you. Thank you. And I guess I could do my camera too. I don't mind doing that. Okay. Hello. Hello, everybody.
Julie's been a huge supporter of Pink Concussions and connected me with researchers, and we have 2 papers out, and you just have always been a huge support. So love you.
Well, we love all the work everyone's doing. Thank you. Because it takes a village, right? Multiple studies. And I've been in the field for a long time. When I was first involved, there wasn't any research on children or mild, or it's just evolved. But I'm looking to see what we can do at CDC to improve the public health perspective. And one of the things I put in the chat was, the highest rate of ED visits is in kids younger than 4. And Tina, we did a paper out of CHOP with that too. They show different symptoms. They aren't in organized sports. And I know that this is a pink and cut. I mean, the focus definitely needs to be on women as well. And Catherine, thank you for raising that. But I'm wondering what folks think about kids outside of sports, because we're learning from our school projects that they don't get the same kind of care because they aren't under return to play laws.
Yeah.
So I'm going to mute my mic while folks answer that, because I have dogs in my room. That's one of the reasons why I muted originally.
Yeah. I mean, I think it's an excellent point. And really, it probably is one of those things where we need to have awareness campaigns in terms of having patients and families recognize that concussions happen outside of sports and kids, and concussions happen in kids younger than school age. And that, again, they may be mild and transient, they recover on their own spontaneously, but sometimes they can have issues where you want to have follow-up. And I think that that's one of the things that I think is a goal actually of another committee that I'm on with the National Academies, is that everyone with a TBI of any sort really ought to have some kind of follow-up just to make sure that everything's fine. And I know someone put in the chat here how they were so frustrated with physicians not really understanding the long-term issues with regard to TBI. And there's a lot of education that can be done both on the medical front with medical providers, as well as with patients. And I think that there's an intersection there. Patients really have to be their own advocates. They have to find and connect with organizations like the brain injury associations of their states. In Pennsylvania, we're lucky to have Brain Steps, which is helpful with kids in school. And so I think from that standpoint, those are all, important avenues where not only do we have to raise awareness in the general public, but also raise the level of awareness among practicing physicians.
And Brenda appeared, I think, 2 weeks ago, 3 weeks ago, to talk about brain steps. I do think that, parent education and just keeping up with that, our parents more educated on TikTok right now than any other social
Yeah.
media. Look at some of these TikTok doctors that have 2 million
Yep.
followers,
Yep.
and just it's following where young parents are. I think nursery schools could be a point of contact, daycares where the education is passed to people at the point at which they're interested. And there's also part of me glad that I didn't really know this much about brain injury when my three boys were learning to walk and they get those eggs on their head when they fell. And but I do think that there's a different generation raising kids, and where are they getting their information? And we have not gotten on TikTok yet. I keep trying to get the interns on us TikTok, but there are different ways that people are being educated other than the flyer or the static
Yeah.
website.
Absolutely. Absolutely. I think that we have to leverage that.
Deneen has her hand up. Deneen, do you have a question? And thank you for hi. I've lost you. Where'd you go?
Hi there.
Hey.
My question has to do with COVID-19 and transitioning students and student athletes back into the school. I don't know, Tina, if you have any recommendations or ideas. I work for a college, and many of the colleges in this area are saying that before students and student athletes can return, they have to have a COVID vaccine shot. So the athletes that I work with are concerned with the long-term effects and how that's going to impact their ability to play. But also I worry about my student athletes that have been diagnosed with a TBI and what that may be like for them as they move forward. So I don't know if you have thoughts on that.
Yeah, no, I think that's a great timely question. Obviously, I think that, our position really would be that everyone should get the COVID-19 vaccine if they are available and an option for them to get. And I think that at this point, the vaccine is definitely going to be much preferred and less risky than getting the natural disease itself. It has been interesting for all of us in the concussion field observing COVID-19 and the whole, phenomenon of long COVID, because long COVID has a lot of overlap with, chronic post-concussion symptoms. And I do think that there probably are some final common mechanistic, physiological pathways that you get to. One path is via concussion, another path may be via COVID, that you would want to address sort of similarly. And we do think that some of that is related to dysautonomia in the autonomic nervous system. But we would not think that COVID-19 vaccine would have a negative impact, in terms of, recovery. Obviously, the timing of the vaccine would be what you would be talking about. There's really not any physiological reason that I would say that even if you had an acute concussion and you just hit your head, within a few days, that you couldn't get the COVID vaccine in a timely fashion. But certainly from that standpoint, we would recommend a COVID-19 vaccine for all of our student athletes for sure.
What about the return to sports after inactivity? We had talked about that due to COVID, people have put on weight. They haven't, people have been sedentary, and when students return to school, you know, are there plans being made around an inactive group moving to suddenly being back into it?
Yeah, well, so again, from that standpoint, I mean, you're catching me, in the middle of my national conference for my professional society, which is the American Medical Society for Sports Medicine. And one of the big emphases was this whole concept of exercise medicine. And the concept also was that, we're trying to make sure that we eliminate barriers for people in terms of exercise medicine. And so in terms of return after COVID, by and large, most people will be able to return to exercise using common sense. And from that standpoint, doing that in a gradual fashion. I think that if you had a prolonged course or anything else concerning in terms of hospitalization or issues with cardiac, complications from COVID, then you would want to see a physician your primary care physician for sure, but then potentially be referred to a cardiologist for testing prior to return to exercise. But other than that, I think that the gradual turn after COVID would be, similar. And certainly in terms of exercise after concussion, we're learning more and more that that is actually a huge part of, again, as long as it's at the right time and at the right dose, it's very beneficial. And that's been demonstrated in terms of, utility and benefit for brain health across the board. So again, if you look at it, exercise is good for depression and anxiety. Exercise is good for migraine. Exercise is good for minimal cognitive decline. And so I think from that standpoint, exercise ends up being the rising tide that raises all ships, and so there's something about exercise and bathing that brain and brain-derived neurotrophic factor that is good for everything. And so I think from that standpoint, I think exercise is a key adjunct, really, in the same way that sleep is something that affects everything. Everyone talks about how sleep is intersectional, that, sleep, is its own entity, but it also influences everything else. And I think that exercise is similar in that same way.
Do you think that there, I mean, I've heard little rumblings of a fear that the long COVID people are going to flood the TBI resources that are stretched as they begin to, and some of the TBI places haven't been as stretched because people haven't been going in for care. But do you see do you see long COVID as an influx of money and interest in the TBI world, or kind of eating up some of the resources?
That's just hard to say, to be honest. I think that unfortunately, all of the resources, it is a limited pie. And so I think from that standpoint, I think, that's way above my pay grade in terms of, anticipating how that is going to play out. But, there's no question that, resources had to be diverted and redirected to COVID, and that was important. Do I think that there are going to be very interesting lessons learned from COVID that are translatable to other fields like TBI? Absolutely. So I think that I prefer maybe not to be competitive about this and say that they're taking money away from us, as to the fact that we're just learning from everything. And I think that all those things are very positive.
And I think most of the world events and sports events have only helped to interest more people in TBI. Certainly, if you look at the NFL stuff. I know Cara has her question up, and then Caleb has a question about hockey. That I know you're a hockey fan. So, Cara, would you want to give your
Sure.
question?
Thank you.
This is our rapid round, since we're close to.
Thank you. I wrote a question, and then I see Elizabeth Wallach wrote a similar question following up. So I just wanted to ask you. My question was initially about looking at the long-term hormonal and neurological effects and impact of TBI on women, and especially since with sports happens younger, and that so everything just from development and moving forward in every aspect, cognitively, neurologically, psychologically, et cetera. And that Elizabeth had asked, have you measured like how long it takes for female teenagers to recover? And are there any statistics like looking at symptoms 5 years later?
Yeah, no, that's a great question. I think that from the standpoint of teenagers, I don't know that we have any really good studies that are 5 years later, and we are interested in that actually, because I am not aware of any really well done large scale studies that tell us how many people have problems 5 years later. Certainly, what we would say is that with regard to like concussion and mild traumatic brain injury, it's not unusual for any teenager to take up to 4 weeks to fully recover and get back to their normal activities. And so from that standpoint, there's good data now, both from the US and Canada, that probably out of all comers with concussions and mild traumatic brain injury, anywhere from a third to even a half may go on to have persistent post-concussive symptoms. And I think the difficulty has been that we've always been lumping them in this big garbage can, of a diagnosis, whereas they probably have very specific, discrete subtypes. So if you have more visual or mood or sleep or cognitive issues, we should be targeting the treatments, more specifically, as opposed to just sort of saying, oh, you've got post-concussive syndrome, and then just dump you in this big garbage can. And so I think, we need to do that study in terms of, 5 years later. And certainly, I think one an anecdote that I guess I would share with you all in terms of, our travels in concussion and treatment is that when we first started actively treating concussion with things like aerobic exercise therapy, vestibular therapy, and vision therapy, we would see kids who were college aged, who had their concussion, a number of years before. And we would now treat them, even though they didn't have a recent concussion, we would treat them. And it seemed to work remarkably well. And so I think what we would often describe in terms of concussion is that the acute concussion with the acute injury, all of those, physiological changes that happen as a result of injury, sort of like the hot part of the concussion, kind of like the hot part of your, ankle sprain, is probably over in that first few days to weeks to maybe a month in terms of like, reequilibrating with regard to like your sugar blood flow regulation, other acute injury phenomenon. What we use a lot in our care of kids is that then you really have to actually like recover and rehabilitate some of those systems that got injured, that basically those systems are now injured and a little bit out of shape. And if they're still out of shape, you're going to have symptoms from them. So if you don't rehabilitate an ankle, you're always going to have problems with that ankle moving forward. And so you don't still say that you have an ankle sprain, but you say, I had an ankle sprain and now I still have problems with that ankle. And so similarly, we would say the same thing about, concussion. If you still are having issues with regard to vision or vestibular or, mood or sleep or exercise intolerance or cognitive, that, again, we can rehabilitate those. We can treat those systems that got injured and are still out of shape. Because they just didn't have it to bounce back on their own. And if they didn't bounce back on their own, we would treat them.
Is that potential for recovery and rehabilitation the same in more severe cases though, or is it more
I
likely
think
that
so.
more
So
severe
here's the
cases
thing. I
will
think that
be more permanently prolonged?
Yeah, no, that's a great question. I think that, maybe it's because I'm like, a pediatrician, but I'm an eternal optimist. And I do take care of some adults in my practice as well. And we do absolutely believe that, and we're learning, more and more all the time, every year, that the brain is extremely plastic. And so even, hope for an old fart like myself, that the brain has a lot of potential, right? It's not just kids. I mean, obviously we have lots of optimism for kids, but even as you get older, the brain is extremely plastic. And so we would absolutely say rehabilitation is an absolute reason for hope for all types of brain trauma.
Thank you.
And then I just wanted to ask, where are we officially with changing the term post-concussion syndrome to prolonged concussion symptoms? And that was our brain injury message for March. And we got so much great feedback about changing our language. Where technically, like in official documentation, medically are we with dropping the syndrome?
So I think that it's moving in that direction, and it's probably at a glacial pace as opposed to anything faster than that. Obviously, when you have, ICD-9 and DSM-5 starting to make some changes in the way that they're describing this and the coding, there's definitely interest amongst professional organizations to come up with something that is better. Obviously, that therein lies the rub, that you do want to have something better to replace it with rather than just yanking it all together. And so I think this whole research and translational research into phenotypes and subtypes hopefully will be helpful. I think it's moving in that direction.
Is there any role for patient advocates to pressure in any way?
Absolutely, absolutely. And I think that even like those National Academy webinars that you participated on, Catherine, are that mechanism. That again, that there are professional organizations, specialty organizations, people who are interested in a multidisciplinary input into statements about where we're headed with this. And I think those are the ways to do it, is to continue to engage.
Yeah, no, I really appreciate, and I have to say, I can't tell you across the continuum from people really respond to not having the syndrome dropped on their heads, to make a bad pun.
Yeah, absolutely.
For Caleb there, any thoughts on the NHL and future concussion realizations? I know you're a hockey family there.
Yeah, I mean, I think that honestly, it's one of those things where I think because it is all tied up in the legal system, that's where the hesitancy comes from, is the liability issue, and so I think from that standpoint, it's just a matter of time. I think that when that all gets resolved, they're just a few years behind the NFL in terms of, Roger Goodell coming out and admitting that concussions are a thing, so I think from that standpoint, it's just a matter of time. I don't know. I don't have any other insight into it as a hockey mom, so I think from that standpoint, it is just one of those things where it has to go through that process. And so that's how that works.
Thank you. And then Nat Dean, do you have a super question? Because I'm keep
Yeah, as a provider and also a survivor, we look at the change in language for post-traumatic stress disorder, removing the word disorder. It's a post-traumatic stress symptoms or syndrome or, whatever that gets replaced with. That's the same kind of advocacy that we can do around changing some of the language around head injury. Thank you so much. This series is great. I just have to give you, like lots of heart emojis. Thank you.
Thank you.
Thank you, Tina, for your time. And next week, Rachel Rowe will be on to discuss endocrine and sleep disruptions after TBI, who works with Dr. Ortez, who came on to talk about the Arizona pediatric study that talked about endocrine disorder in female pediatric patients. So thank you, Tina. Thank you, everyone. This was when you were on, Tina, this was a 4-week series. And you are number 2, and I'm really happy to have you as I think you're under number 16 or 17 now. So thank you so much, and we'll see you back in 6 months.
Thanks. Bye-bye.
Take care, everyone. Bye-bye. Thank you all.